Thank you very much for that introduction. As I walked in, I noticed that I hope they gave everybody one of these flash drives, because at first I thought this was the talk they wanted me to give. but instead you're getting the talk that I brought. And this is a big topic. So I was charged with discussing what the One Health challenges are for the 21st century. And one of the challenges that I'm going to talk about is communication. And if you read the wall when you walked in for the quote from Lister Hill, there's a quote about communication being so necessary. And I think that's something that will come out of the next day and a half. So as I looked at the challenges that we face in One Health for this century, I think one of the biggest challenges is just defining what One Health is, and then changing the culture of science and medicine as they relate to One Health, and then communicating that message effectively. And finally, we need to get better at being able to predict and prepare for the future, and that's going to become not only critical in translational medicine, but also in global health issues. So challenge one of defining One Health. It really depends on your audience. If you ask people what One Health is, you'll get very different answers. So if you're in a veterinary community and you ask what is One Health, I think we get it. So we see a lot of enthusiasm for One Health, and it's kind of natural in our discipline. However, when I give the talk to other audiences, including physicians, I'm a little disappointed sometimes. We think we're making a lot of progress, and sometimes I feel like we can't get out there enough to spread the word about One Health. So if someone were to ask me what One Health was, how would I define that? Well, fortunately, there was a task force that was tasked with that to define what One Health was. And in July of 2008, this is the definition that came out. I'm sure we're going to see this more than once over the next day and a half. But One Health is the collaborative effort of multiple disciplines working locally, nationally, and globally to attain optimal health for people, animals, and our environment. And this was the definition that was arrived at back in 2008. What is still being determined, I think, is the scope of what that means. And I purposely put this slide where the print is very small because I think that brings emphasis to the many different things that we try to put under this One Health umbrella. And I think we've all seen the One Health umbrella slide, but what always interests me on this slide is that we have really two pretty distinct areas underneath the whole One Health umbrella, one of zoonotic infections and one of comparative medicine translational science. And I find that when I go to One Health meetings, oftentimes they're very much slanted one way or the other. But it's important that we think about how all of these work together. And sometimes it feels like there's just too many umbrellas, and we need to make sure that our area is that we're paying attention to our individual areas as they fit underneath that larger umbrella. And by that, I mean we truly need to make sure that while we're thinking about human health and while we're thinking about companion animals and agriculture, we're also thinking about the environment and the interplay between all of those areas. So where does veterinary medicine fit in One Health? Well, I think we're a pretty big part of it. And I think when people think about what veterinarians do, the MDs hate this slide, and I apologize for any MDs in the audience. But I think veterinarians are used to thinking about things more globally, more holistically as part of our profession. And so I think sometimes it's a little bit easier for us to get it and making sure that others in our groups are getting the message is a little bit easier, I think. And this isn't a new idea that veterinarians need to be involved in this. This was from 2005. The publication came out of National Academies Press talking about the vital role of veterinary research in human society. And in that, they showed that really where interdisciplinary research in veterinary sciences is right at the heart of all these areas between human health, wildlife and ecosystem health, and domestic animal health. So I think people from disciplines outside of veterinary medicine oftentimes think of veterinarians as being more involved in the zoonotic disease aspect of it, the agricultural aspect of it. And certainly that's something that's become important in recent years to an even greater extent. if you were to ask us what we see as our role in this aspect under that umbrella, I think we could all verbalize different areas that we think we could play a vital role. And I think it's going to become even more vital because our society is becoming a lot more mobile. So we're moving among populations. Our pets are moving amongst populations. And so in terms of disease spread, that brings a lot of new challenges, as we've seen. Now, I put this up because it speaks a little bit to my personal interest in One Health, beyond that of being a comparative oncologist. My late husband and I adopted 2 boys from Liberia about 10 years ago. And 10 years ago, most people in America didn't know where Liberia was. Suddenly, I'm pretty sure most people know. And we adopted them in October, and I was reading the youngest one a book, or showing him a book called Stranger in the Woods. And as I went through the book, I said, do you know what this animal is? And each page has a new animal that shows up. So I said, do you know what this animal is? And my youngest, who was 5 at the time, said, yes. And I said, what is that? And he said, meat. So then I turned the page, and the new animal showed up. And I said, do you know what this animal is? And he said, yes. And I said, what is it? And he said, meat. And so suddenly I realized not only was it very strange for him to be in an environment where there were snowmen and he'd never seen snow in his life, but he saw the world very differently than I did. And that's been a real eye-opener for me, and hopefully it's something that will translate to an eye-opening experience for others as we think much more globally and where we fit in that global scene. So we do have concerns about that interface between wildlife and agriculture and our environment with human and companion animal health, and it's a very real concern. And I think in order to protect those global populations, veterinarians need to be specifically involved in that, and I hope that'll come out from some other discussions over the next day and a half. Sorry, I have allergies, and I took allergy medicine, and my mouth is dry. So the other area of One Health that fits under that umbrella is that of comparative medicine and translational research. And this is really, as a comparative oncologist, this is where I initially came at this topic. So again, I think it's natural for us to think of where we fit as veterinarians in each of these different areas and the important role that we play in translating these models. So as veterinarians, we may be working on everything from zebrafish models to looking at populations within our environment, to looking at dog models, to looking at the death trap model. If you're a cat lover, you're not going to like this talk. I apologize. But this is one of my favorite quotes that I use in oncology, and that is that cancer, unlike politics and religion, is not a topic of controversy. No one is for it. And this was written by a veterinary technician. And it's very true. I mean, we're all dealing with the same disease. We're dealing with the same concerns for the large part, just different species. And I would say that you could replace that word cancer by whatever disease X you study. We're all in this together in terms of fighting the same pathogens, fighting the same diseases, and what we learn in one area hopefully will help inform decisions in other areas. So just a snapshot of when I think about One Health and translational medicine, where I am at the University of Missouri, it could mean everything from comparative neurology to comparative orthopedics to folks working in our comparative medicine laboratory on feline asthma as a model of human disease. So all across the board, there are opportunities for this type of interaction. But I really think we need to change the whole culture of science and medicine. And those of us that say we get it when it comes to One Health need to learn how to help others come to that same understanding. Now, my background is I had physicians in my family, but no veterinarians. So this was my grandfather, circa 1938. He was a physician. This is my uncle, whose name is Bob, and I recently heard the "and Bob's your uncle" phrase in England. I thought that was hilarious. But anyway, so with this background, they really thought that I should become a physician, and I had interest in medicine. But I went into veterinary medicine the reason all veterinarians go into veterinary medicine. Do you guys know what that is? You love animals? No, not really. because people are gross. But I do love animals. But back to my grandfather. So my grandfather was a physician, but he developed Lou Gehrig's disease. And my grandfather died in the early 70s of Lou Gehrig's disease. And when I think about that, and I see folks on our own campus doing research into animal models of Lou Gehrig's disease, I become more hopeful that we may come to answers on this. But I remain very frustrated that in 40 years' time, we're not handling that disease any better than we did in the 70s. And so there's got to be a better way. And I think one problem is we keep doing things the same way. And just because that's how we've always done it doesn't mean that's how we should continue to do it. If it's working, yes. If it's taken you 40 years to make any movement towards a cure for a disease, maybe we should rethink how we're doing this. And one of the things from an oncologist standpoint that I'm faced with is the fact that the first step in most traditional research and development is with a mouse model. And mouse models are great, and they've created a lot of PhD theses. And they do have their place, don't get me wrong, but I think we need to also consider other models that can strengthen them. We tend to pick the mouse model because things can go rapidly in that species. So shorter lifespan, experiments can be completed more quickly, more controlled. But when we think about how that's resulted in drug development, that may not always be the shortest route or the best route. And case in point, you've all, I'm sure, seen some version of this graph that shows that for every one FDA-approved drug, 5,000 to 10,000 drugs started into that pipeline. And it's not even so much the number of drugs that concerns me as the number of years that it really takes. And this is not an indictment of the FDA, certainly, and I'm not just saying that because I'm sensitive to being where I am right now, but it's an indictment of what we've used as our models, what we've used as our study endpoints, and it's just a wake-up call that we need to think through how to do this differently. And a wake-up call that came as early as 2004, there was an article that came out in Fortune magazine about why we're losing the war on cancer. And in that article, came right out and said that the models that we're using stink. Not that eloquent way to say it, but truthful, in that maybe there needs to be another way to look at these besides just mouse models. So I do think we need laboratory animal models. Again, don't get me wrong, there's certainly a place for them. But I think there might be an area where we could use some additional information in terms of if we look at things like cancer therapies. If we create cancer in an incompetent, immune-incompetent animal, that's not really recapitulating the same results that we're likely to get in a human patient with cancer. We're not studying the natural course of disease. The disease progresses rather rapidly, and so if you want to look at therapies in the minimal disease setting, this probably isn't the best way to do it. And then there are biosampling limitations. I didn't go into cancer research involving mice, one, because I'm scared of mice, and secondly, I'm really cruddy at getting tail vein samples. So when we're working with larger models, we can get larger samples. I'm scared of mice because I worked in a pet shop, and I used to have to clean the mouse cages, and no one told me that all the mice learned to jump out of the bucket at the same day. And so things were going along fine, and then I had like a bunch of mice jump on me. So that's my mouse horror story. So do we need to change our tune? Well, yeah, I think we do. And I think we need to look at other players in this, and I think companion animals may have a very important role to play, and I'm sure others will be mentioning this throughout the next day and a half. So if we just look at the population, look at the numbers that we have to work with, about 40% of us own a dog, and about 24% of us have 2 dogs. And that's about 77.4 million dogs by the most recent statistics that I could find. A little bit fewer cats. Again, apologies to the cat people. And if we look at veterinary clinic visits, they're actually going up for dogs, up about 9.2% between 2006 and 2011, going down a little bit for cats, probably because they are that weird reclusive roommate. But in my area of cancer, this is an area that we see so many animals, or so many dogs especially, diagnosed with cancer. It's the leading cause of death in dogs. about 1 in 4 dogs are going to die of cancer, and about half of the dogs that live to be 10 years of age are going to develop cancer. Now, you get the question, are we seeing more cancer because it's occurring more often, or are we diagnosing it more? And my answer to that is yes. I think a little bit of both, and I think our clients are becoming more savvy with information on the internet. They now know what's truly available for treatment options, and I think it's becoming a little bit more socially acceptable than it used to be. So if we look at just how often does cancer occur in animals versus companion animals versus people, and the numbers would suggest that we see it more in dogs than even occurs in people. And, you know, that's something as a veterinary profession we know because we see these cases coming in. But when I talk to a lot of the colleagues on the physician side of things, I kind of get, you know, who knew? Yeah, I still get that question, dogs get cancer? Yeah, they get cancer, and then as veterinarians, we give them that look. But it's second nature for us to think about that, and once we speak to others about it, it becomes more obvious to them. So as a veterinary oncologist viewpoint on One Health, you know, I look across the campus where I am, and we've got everything from a human cancer center that's the only academic affiliate with MD Anderson, to a research reactor, to the teaching hospital. And sometimes I will get asked to do interviews, and they'll say, can we meet you in your laboratory? And I think they're expecting brightly colored fluids and beakers and things like that. And instead I say, sure, meet me in the teaching hospital. This is our clinic for many of us, and this is where we do our research. It's no less important than research done in a laboratory. It may not be any more important either, but it's something that should be a vital part of the full process. So what's so great about these companion animal models? And I'm going to be focusing a little bit on dogs because you've already figured out that I like dogs. But why are they useful? Well, first of all, they share our environment, and that's incredibly important when we're looking at things like cancer etiology. When we see cancers occurring in areas with unrelated animals developing it, that should be a wake-up call to us that maybe there's something there that needs to be a concern for people. There are other advantages that relate to the fact that we don't tend to have a standard of care for all diseases. You know, that sounds like a bad thing if you're practicing medicine, but in the case of our veterinary patients, it gives us a little bit more latitude to try new things. Their anatomical size and structure is very similar, so that's an advantage. And again, we can assess long-term outcome, which is a vital thing that we can't always get from rodent models. And then there are the things that we can control in our companion animal patients better than I think can be controlled in people. So things like lifestyle choices, diet, hormonal status. How many in the crowd would like to volunteer for a castration study? Yeah, not going to happen, but that's something that we can look at in our animal models. And the placebo effect would be nice if we could completely get rid of that, but if you've worked with owners, you know that if an owner really wants something to work, they're going to think it works sometimes. So we can't completely eliminate that, but it is more controlled. And they have a shorter lifespan. As pet owners, that's not good news, but as researchers that want to look at outcome over the lifetime of a patient, this is something that we can do more efficiently in companion animals. And then the big one to me as an oncologist, I think, is that we're looking at the disease that occurs just like it would occur in you or I. Things like lymphoma occurring that literally can come up overnight. Primary lung cancer. And this one was actually, it's the belly of a dog that came in with oral melanoma. And we were doing an abdominal ultrasound looking for metastatic disease. And as soon as we clipped the belly, we didn't need to do the ultrasound. So this is a disease that looks very similar to cutaneous melanoma in people in terms of its metastatic behavior. And then we can image our animals. A lot of people don't realize that we have all the same imaging technologies available in veterinary medicine that are available in human medicine. So we can do CTs, we can do PET scans, MRIs, radiographs, fluoroscopy. All of that can be done on the same facility where we're able to do these studies. So I've made the case that we've got a model that looks pretty good, but sometimes pretty good isn't good enough. So how can we even refine that to a better degree? Well, in animal models where we're getting more and more information about the genome, it becomes easier to really select your population that needs to be studied for specific diseases. And so the Dog Genome Project has helped with that and allows us to really narrow down the focus of where we need to be looking for genetic mutations and even epigenetic findings. So if we have a set of dogs that gets a similar disease and can find a similar alteration in the genome, then that gives us a clue where we need to look for disease interventions, and it really narrows that down in a way you couldn't do with human populations. So in animals that come from purebred populations, we do see certain cancers that occur in certain breeds more than others. This is the part where you look at the slide and you find your dog, and then you get really paranoid for the next week that your dog has one of these diseases. And if you own a golden retriever, just stay paranoid. That's what I have. But for instance, I have a real interest in bladder cancer, and Scottish Terriers get it way more than any other breed. And you know, that would suggest there are genetic reasons that occurs. And it would also suggest that that's a pretty interesting model to look at if we're thinking about etiology and therapy interventions. And then our approvals are somewhat simplified in veterinary medicine, so we don't have quite the red tape to go through. We still do have some. We don't have a lot of third-party payer issues, which makes decision-making a little easier in terms of what's available to our clients. Doesn't always make it affordable to our clients. And then we do still have HIPAA issues in veterinary medicine, but not necessarily to the same degree that is seen in human medicine. And then one that is important, but we don't always think about it, is the fact that we can do repeat biopsy samples in veterinary cancer patients. And we do tend to get necropsy a lot more often, or autopsy more often than is seen on the human side. And what that does for us is it allows us to take an animal like this that has masses that could be removed surgically perhaps, and put them on a trial where we want to prove that we can target tumor tissue and not normal tissue. So then what we can do is get a biopsy of normal tissue, a biopsy of tumor tissue, give the drug intervention, come back the next day, do the same 2 biopsies again, and show that it did target the tumor tissue and not the normal tissue. And that's exactly what we did in one of our first, I think it was COTSI-1, one of our clinical trials run through the consortium here. And so basically we had pre-treatment and post-treatment could show that we got targeting of the tumor and we did not get targeting of the normal tissue. So, you know, a very simple design, but something that would be nearly impossible to do in a human study. And then we can go on and offer interventions for those pets as a way to incentivize it for their owners. And this might mean that dogs and cats can get treatments that they otherwise wouldn't be able to because of cost issues. And then finally, we have the same therapy options. So the larger veterinary institutions have radiation facilities. And so, you know, if we're looking at things like brain tumors and doing radiation therapy on those, we have the facilities and we are treating patients on a regular basis. So we hear a lot about the bench-to-bedside approach, and what I would suggest is even better than that is to put a veterinarian in the mix there and develop rather a bench-to-cage side to bedside approach. And by doing this, it becomes a win for the veterinary community and our patients as well as for the human patients. And this is an idea that has begun to take hold. One of the first evidence of that was the Comparative Oncology Trials Consortium, which was developed in 2006 under the NCI umbrella. Basically a consortium of veterinary institutions, teaching hospitals that had board-certified oncologists and adequate setup to do high-quality clinical trials. And then we also saw the development of the Canine Comparative Oncology and Genomics Consortium, or CCOGC, which was developed to collect tissues from dogs that presented with specific tumor types that were good models for human disease. So things like osteosarcoma, lung cancer. We would get samples from those patients, 13 different samples with SOPs for each one of them, and send those to this biospecimen repository. What that means is now we have bank samples that can be acquired by researchers that need access to specific tumor types, whether it's DNA, cells, what have you. Those are available through this biospecimen repository. So it has given researchers access to our patients that I think is important, and has helped guide the movement from preclinical to clinical trials. In 2008, we actually had a meeting here at the NIH where we talked about this issue of how do we translate new cancer treatments from canine to human cancer patients. And I think there's going to be some more discussion of that in the oncology section of this symposium. So we started out, I think, with 8 institutions. We now have 20. I think this is a poor representation of Canada. And I also noticed, I was given this talk in Alabama the other day, and I noticed that Arkansas also has an AL here. So I live in Missouri, and I can tell you that they're not this, well, they kind of are the same, actually. But Alabama has a star, so I told them they were better. But what have we done with that? Well, you know, there's this publication that talks about this novel preclinical infrastructure that's been set up as part of this process. And that first study that I talked about, where we looked at how can we target tumor necrosis factor alpha to cancer vasculature. Again, very simple design, but something that needed to be done and something that needed to be done efficiently, both from a cost and a time standpoint. So does it work? Well, I decided rather than pick on any other school, I would just give you Missouri examples of things. And I'll tell you that in the state of Missouri, we have this saying that we're the show me state. You've got to show me. And that came from William Duncan Vandiver. And that's sort of been our approach to any new therapies coming through in oncology. But one that has worked, and a good example of how you can do this through collaboration, I think, is that we had a product that was developed at the research reactor at our university, and it was a samarium compound. It was found to target areas of bone that were very active, so things like metastatic disease would have uptake of this compound. And so it was tested actually in dog models that had bone cancer, looked promising from there, and then was picked up by the Dow Chemical Company and eventually went into human use and is available today under the name Quadramet. So this is just one example of how literally something was taken from invention stage through preclinical and into clinical on one campus with people working together. And so it really, I think, encapsulates the idea that we need to get the right people in the right setting together working on these projects, and we can do it in a way that's more efficient. So I would say that clinical research using animal models is a win-win for more reasons than just outcome of a product. But I mean, let's face it, we're facing some pretty difficult times in terms of funding opportunities. And again, you can get these off of this website for any state you're in. I just picked Missouri, so I wouldn't be singling anybody else out. But if you look at state funding facts for fiscal year 2014, you'll see that we had 21% lost funding. As I went through and pulled up other states, everybody was at 21 to 23% loss of funding. So it's happening across the board, and we've got to find ways to be more creative and more efficient with the money that's available. One way we can do that helps the human medical side of things is through a lot of these foundations that are developing. So there are breed-specific diseases that may be of interest for funding, and there are certainly a lot of animal groups, animal foundations that want to help sponsor this type of research. So that can be a good reason to partner with veterinarians. If you look at the Star Metrics website, which gives you funding from these sources across the board, a little bit of good news on the One Health side, I would say. So I went through and I looked at, you can put in the year that you want to look at, and I just did searches under the term One Health to see how that landscape had changed over several years. And it will pull up all of the One Health related grants that are funded. And in this example, there were over 57,000 that were in 2009. If you look at the trend, though, we obviously started One Health idea right around here, and look at how it has grown. And that's in face of even the funding challenges that we have. We haven't We haven't grown really since the peak at 2010, but we're starting to see hopefully a recovery from some of this financial issue that we've had in terms of funding for these studies. But it's another source. If we can have a One Health approach, we may be able to share resources not only in terms of human capital, but also in terms of funding capital. So how do we communicate the One Health message? And I think this is one of our bigger challenges, in fact. We would like to think everybody gets this and everybody knows what we're talking about when we say One Health, but they don't. And we need to quit waiting for that to happen and really become more proactive about getting the word out there. And meetings like this will hopefully facilitate that. So the One Health Initiative website is one way that people can access this idea. It was initiated in October of 2008. The last figures I saw, they estimated they had 20,000 visitors a month, and those were from 150 different countries. And they also have a lot of reciprocal links. So they have over 100 reciprocal links to other websites. So really trying to expand that network to new audiences. And they also give weekly updates on One Health related issues. The stated objective of the One Health Initiative is to promote and improve the health of humans, animals, and our environment, both individually and collectively, by encouraging and ensuring the acceptance and adoption of One Health. And that's where we need to come in terms of the intervention and make sure that that is accepted and adopted in the way that we do science. The One Health Commission is one of the groups that we all think about, I think, when we're talking about One Health, and that they've really spread this idea of world health through collaboration. And this group was chartered in 2009 as a nonprofit organization under veterinarian Dr. Roger Marr. And then Cheryl Stroud took over in 2013, and it has since moved from Iowa to North Carolina under her leadership. The other thing that's happened is a movement in terminology. In 2014, they added the word plants to the mission. And so, as was mentioned earlier, we're now looking at how all of this interplays with our environment, including plants. And so now the stated mission includes the word plants in this global One Health approach idea. And when they talk about how they promote these types of things, I mean, as a 501c3 nonprofit, they have the ability to fund some of these activities. But more importantly, they really promote the idea of connect, create, and educate. And that, I think those are some of our challenges that we need to address at this conference and others. So at the AAVMC conference last year, which is the American Association of Veterinary Medical Colleges, that was actually based on One Health. The whole topic for the conference was One Health. And when asked to put words in that made this wordle, these are the things that came out. So this is a veterinary audience, and these are the things that we think of in terms of One Health. And we're trying to spread that word through other mechanisms, through things like online conferences. There was one in November that was the first international Who's Who in One Health webinar. I don't know how many of you attended that, but it was, I think, the start of something that is on a more global basis. And I think all of these are important. I think we need to quit preaching to the choir, though, because we get it. We need to get out there and reach the audiences that this is still very new to them. And we also need a choir director. And I think one problem that we're having is One Health means something different to everybody. And we need to make sure that we're all talking the same talk, sharing the same message, and doing this in a way that's very collaborative and organized. If you go on the web and look for things that reference One Health, you get more than you know what to do with. And some of these are ones that we would all recognize, so things like the One Health Initiative, One Health Commission. Others are not anything to even do with One Health in terms of human, animal, and plant convergence. This one is a group for folks with abuse problems. And so you may get to a lot of different sites as a layperson and not be able to sort through those and understand what One Health is. And one of the newer ones I saw was the One Health platform. And this I was looking into because they now have a journal on One Health that's starting out this year. And I wanted to learn more about that journal. When I went onto their website, this came up. And I think that really kind of sums up where we are. It's a very evolving process. We're all doing our own thing to try to make it a more collaborative and conscientious way of doing things. But in reality, it's evolving every day. So how do we face that? And how do we predict the future and plan for the future in face of that evolution? Well, historically, our approach has been wait till there's a disaster and then do something about it. And I would like to propose that we need to get teams in place that can respond to this evolution, respond to changes that are occurring. So I don't know how many of you were mesmerized by this on the web. There was a big thing about, is it a white dress? Is it a blue dress? And I think when we come at this from many different disciplines, we're going to look at it a little bit differently. But I think when there's a problem, we can all recognize that. And so we need to again, put these teams in place and train those teams. We're going to be talking about training tomorrow, and I think that's going to be vital to this effort. So an example recently has been the Ebola virus. And, you know, this is a kid not different from my kid that would call anything meat. There's going to be the exposure potential, and where veterinarians can be very important is finding ways to address that in meaningful ways to help stop the disease spread. And then something as simple as, what do we do with dogs or cats that are brought in to our hospitals that may have been exposed? We did have cases, obviously, coming back to the U.S., and so it's a concern. I was sharing with someone this morning, I have an appointment at the med school, and so I get all the med school mail as well. And they sent out our official, this is how you're going to handle any potential Ebola patient. And it was one day after the nurse in Spain's dog had been euthanized because it might have been an exposure risk. And so I wrote to the dean when I got the email, and I said, how about we add something onto that about, and if they have a pet, why don't we quarantine them and learn something about it rather than euthanize them in a very reactionary way? And so, you know, I think it's going to become even more important for veterinarians to play a role in these types of interventions. And in veterinary medicine, let's be honest, our landscape is really changing from where it was. Vet school's not cheap. And I saw some numbers last week that were really alarming about return on investment for veterinary students. There were basically 3 areas where you got a positive return on investment, and that was industry, so pharmaceutical industry, regulatory, and academics. And all the rest of them, you had to be a vet till you were well over 65 to really see a return on the investment that goes into that education. And so, you know, we need to train our students for those jobs that are going to give them that positive return on investment. And so how can we take that and turn it into something positive from a One Health standpoint? Well, I think we need to look at training opportunities, and we need to train these students to react to the jobs of the future. Wouldn't this be fantastic? I think we don't know exactly what tools they're going to need to reach these problems of the future, but we need to be thinking in that direction and trying to provide those tools. And when we learn we're not providing them, adjust our curriculum. So this is an example of a program that I'm working on at University of Missouri called a Global Innovation Fellowship Training Program. And the idea here is that we will do fellowship training where we put people from all different kinds of disciplines together to address global health issues. And what may seem out of place here, we have medicine, we have engineering, so you can think bioengineering, things like that make sense. Business is there if there is some commercial aspect that comes out of this, some new widget or some new diagnostic test that could potentially have commercialization potential. A business student could learn from that experience. But we also have a journalism school, and I spoke to some folks that were doing internships in Washington and said, you know, as a journalism student, would you have an interest in being immersed in a fellowship that dealt with global health issues? And they wanted to have that training. And groups like the USDA, I think, would be appreciative of people that had that training, because we can come up with the best interventions in the world to address world health problems, but if they're not going to be implemented in that culture, in that society, it doesn't matter. So we need to have people that understand, that can do the background work, really understand what the issues are there, and then communicate it appropriately and show us how to communicate it appropriately. As veterinarians and physicians and researchers, we're not necessarily trained in how to communicate a message. And it becomes vitally important in some of these global issues that we do that effectively. So the concept is we want to approach the same problem, but from a lot of different perspectives. So when I had medicine up there, that's actually DVM and MD. So we're going to pair up teams. We're probably going to even throw some DOs in there because I've seen that DOs and MDs sometimes approach problems differently. But really put people outside of their normal comfort level, but allow them to experience what it's like to look at something from someone else's perspective. And I think these are the types of students that we need to be developing in our programs. That will allow us to also leverage different funding opportunities from a lot of different areas. It plays to some of our unique strengths, and importantly, it expands that overall culture of collaboration that's going to be so important. So what we really need to do is take it from a problem identification to implementation of a solution, and that implementation is key. And to do that, we really need to become more collaborative and more proactive. I think in the past we've tended to want to work in our silos, and we've tended to just react to things that are happening and create solutions then. And I like to propose that we become collaborative so that we can have the solutions in hand when the problems develop. And so, you hear a lot, we need to think outside the box. Well, I like this quote. I think we just need to get rid of the box. And I think we need to start thinking completely different about how we approach these issues. And it's creative, but it's really just a matter of connecting people that should be working together. And once it happens, if you guys are, any of you coming from campuses, for example, that have One Health programs, it becomes really a part of your culture and a very natural thing once you do it. It doesn't seem unusual, but it's that first effort to get people working together that's sometimes difficult. And once you do that, I like to say it's like intelligence having fun. It's so much fun to be in an environment where you can get different input from a lot of different types of people from various backgrounds and address these problems. So what's our next step? And hopefully the rest of you that are speaking over the next day and a half will add your comments to what you think the next step is. But I think we could use some help. And where we could use some help is in this communication aspect. And I want to give an example for those of you that don't know about it. There's something coming up in June that I think is kind of a big deal. And Rod Page is to be congratulated for his effort in this. And that is that we're having an audience with Institute of Medicine on the role of clinical studies for pets with naturally occurring tumors in translational cancer research. So this is one of the first times a group like this has come together and had an audience where we can say this is the value and this is how we want to be incorporated in the overall objectives. And so this will be a 2-day conference in June. If you haven't seen it and it's of interest, the website's very helpful, and I'd encourage you to take part in the workshop. And I was trying to leave about 15 minutes for questions, so I think we're right on time with that. And I'd just like to say thank you so much for this opportunity. I love to talk about One Health wherever I go, and I especially love talking about One Health in an audience like this that is so varied and hopefully will bring fresh new insight to some of these issues. So thank you very much. This is the part where we find out what kind of audience we're going to be for the next day and a half. Does anybody have any questions or comments? Would be welcome as well. Yes?
So I'm struck by your oncology-ness, and the question is, can you point, you showed the Steve Labuti article about TNF targeting of the endothelium. Is there any examples you could give of things that have gone from companion pets into humans?
Yeah,
it's a success.
Yeah,
because that was an experimental approach that he was using.
Yeah, that's a tricky thing to answer because I know we got FDA people in the room as well. But oftentimes there are interventions that can occur in animals very similar to what's occurring in people with drugs that are just a little bit different. So an example there would be receptor tyrosine kinase inhibitors. We now have the first approved receptor tyrosine kinase inhibitor in dogs for treatment of cancer. So that's one example where those became very useful on the human side, but we also were able to bring them in on the veterinary side. You mentioned Steve Labuti. What was so interesting to me is I was actually at a nanomedicine meeting in France, and I had never met him, but I knew who he was from being involved in that study. And he put up a slide of a dog, and I was like, I know that dog. And it was one that we had put on the trial. And so, he had then taken that to clinical trials in people. And so as a researcher, that was really rewarding for me to see that. And it struck me as a little unusual. I had to go to France to see that. But, just an idea of how different environments are becoming cross-related in the industry today. Out of the research reactor, which is my biggest experience, we've got 3 FDA-approved drugs that came out of that. So samarium is one for bone targeting, and then we have others for imaging as well. So that's one I've got some personal experience with. And then another one that you could point to would be some of the vaccines, cancer vaccines that are being developed. There is one that's FDA or USDA approved for use in dogs, and that same sort of technology is now being tested in people. I got a question the other day. I was at a One Health Summit, and somebody from industry was talking about the market for animal drugs. And he was trying to convey the message that you're not going to make any money off of the animal health industry. And he made the comment, he said, so how many drugs do you think are approved for use in dogs with cancer? And then he said 1. Well, there are some conditionally approved ones, so there's a little bit more to that story. But I think what we need to reflect on is veterinary oncology has only been a specialty for about 20 years. And if you look at the time frame it takes to go from beginning of drug to approval, we're still playing catch up. But I would say there's a lot more MUMS applications type drugs that are going through the pipeline. And I think we may see some more repurposing of drugs as well. Oh, wow. Yes.
Are there data yet that show that if you go through a companion animal model, that your time to market for a human drug is actually can be made shorter? So I'm just thinking of ways that you incentivize funding sources.
Right.
I know there was a slide that I saw in a talk probably 2 years ago, and they showed a theoretical curve of how it might impact time to market. Any data on that?
I haven't seen any that would show something that had gone to market. I can tell you that we've killed drugs earlier because of some results. And, in my mind, that's the savings as well. I was involved in a drug that showed some toxicity in dogs that was later found in people. And so it was killed early in that trial. So I'm more familiar with that side of things. But I think we're early in this, and it's going to take some wins that we can look at the span of time and compare it to what it's normally taking. And the advantage we have with companion animal model studies is by the time a pharmaceutical company comes to us and wants us to do a preclinical trial, they've already got the tox data. So, we're not starting from step 1. We can then take that tox data and the PK data and apply it to how we're going to set up a trial in dogs. Yes?
Yeah, I'd have 2 questions. One is how are you finding, especially with cancer drugs, it seems like when you're trying to get something through FDA, you've got often the push to get a GLP study done or a GCP study done. And especially the tox trials are not minimal, because when you do need to do a tox trial, the cost is prohibitive, and it's often difficult to find a facility to do it. How do you envision going forward in using companion animals to get into the question was brought up to get a drug approved quicker for FDA use,
right,
with those limitations, and then how we should be going forward in developing GLP, GCP, those type of.
Well, I think if you work, for instance, with the groups in COTC, those are all at universities. Those are places that are used to doing GCP, GLP type trials. We've gone through FDA audits. So if you work with groups that have a clinical trials office or a clinical trials service, I think those are the ones that can do those types of trials. And the other part of cost savings is looking at what's your endpoint. So your endpoint doesn't necessarily need to be response or survival time. It might be proof of targeting, proof of concept. So in that regard, oftentimes we can do a rather inexpensive trial in a shorter period of time while the human trial is progressing, and really inform those trials. And I think Amy LeBlanc is going to be speaking to that a bit tomorrow or maybe later today when we talk about our collaboration through the NCI. Thank you, sir.
So you pointed to analogies involving boxes, liver boxes, boxes. I want to talk about sandboxes.
Yeah.
And playing at the same
Yeah.
sandbox. And in particular, the multi-center approach, which is, of course, utilized in human medicine, also utilized in veterinary medicine. But speak more so to your background with the consortium. I know you've been involved in multiple multi-center trials. So speak to how that evolves from a veterinary perspective.
And that's, I come at it from two different perspectives. So in terms of doing prospective trials, for instance, in the veterinary community, that used to be a big problem because there would be certain groups that were kind of the big groups, and they would do the trials, and the smaller ones would not be included. And actually, I shouldn't even admit this because I'm being taped, but I started a group many years ago called LOCOG. There was VCOG, which was the Veterinary Cooperative Oncology Group, and I started LOCOG, which was the left out oncologist. And we didn't tell anybody what it stood for. We just had our meetings. But, there was that sense that all the little guys needed to band together to make this happen. And I think, to some degree, trying to get patient accrual in a meaningful way, trying to get studies done quickly, I think that realization is kind of out there, and certainly the funding issues have helped us in that regard because you kind of got to play in the sandbox. Where I see problems in institutions like an academic setting is it's difficult to get people to work across disciplines because you have issues of what different departments are going to count towards tenure. You got issues of authorship. You've got issues of who's PI on grants and things like that. So I think there has to be an administrative buy-in on that as well. And then finally, things like SPORE grants in cancer research really encourage having these centers and having multidisciplinarity to those centers. So not just multidiscipline across your campus, but reaching out to other campuses. So, unfortunately, my answer to that is the quickest way to get people playing in the same sandbox is to take away the money and then say you only get the money back if you work together. And the economy has kind of forced us into that to some degree. Did you have other insights?
No, I was thinking more so just as you say in terms of the accrual
Mm-hmm.
issue. And so I'm coming at it from the perspective of one who is doing research in the muscular dystrophy field, which is an orphan disease. Of course, this is a point that I'm right to making hot dog out. But there it's so critical to be able to accrue patients across multiple
Right.
centers. And so much attention paid to consistency of biomarkers where you can conduct trials across centers and nonetheless have the same reliable, transferable biomarkers.
Right. And, I probably not quite to the same degree in neurology, but certainly in oncology, we've got better databases now for having searchable databases for clinical trials. And I think that's going to become really important because our, clients go onto those websites and it'll show you tumor type, where it is, where geographically the center is. And so I think using mechanisms like that will help us get word out for accrual as well.
Just a case in point, how many ongoing trials are there at Missouri?
I think we've got 8 or 9.
How many of those are multi-center trials?
Probably 4 or 5. And I think you need a mix. I mean, as you said, sometimes it may be something that you really want to confine to your site so you've got the same people looking at the same things. Others, case accrual is more important and numbers are going to be more important to you. Michael?
Excellent talk again.
Thank you.
Great overview of all of the different topics and discussion. You did mention the CTSAs as a potential avenue, and I think the schools that are associated with CTSAs are also in part integrated within that, and the Comprehensive Cancer Center certainly as well. Do you see opportunities within the CTSAs?
Oh, absolutely. Yeah, and I think those are key. Also on the veterinary side of things, because not all CTSAs have that, and I think where that's available, it really opens up avenues for research that couldn't be done otherwise. So, yeah, I didn't want to steal the CTSA thunder from the speaker on that, but I think that's the kind of thing that we need more of.
And the other comment would be, as a viral oncologist, we're citing examples of where we need to be relevant, but actually, historically, it's also important to point out where decades earlier, we already knew about the concepts and the viruses and the etiology. I think those
Exactly.
examples are good as well.
Exactly, and I don't know if that'll come up in the HIV talk or not, but certainly animal models have been important in that aspect. Yes, sir.
You mentioned that important facility in Canada, and you also mentioned your trip to France. What type of international outreach has there been made, say, with the Germans, the French, the Brits, the Japanese? I mean, you have Helmholtz, you have Institut Pasteur, you have Karolinska in Sweden. Do they have any input, or have they been involved at all in any activities that you folks have been undertaking?
Yeah, and I think that's going to grow. In fact, that new website that I showed you, that's out of Belgium, I think. So certainly there are spots here and there, but getting them all connected under one site is where it's going to be important. We actually had a conference in Prague that was on controversies in veterinary medicine based on One Health. And so I got to see from more of a European perspective where that's occurring. And I think culturally there are some real differences between countries that will affect the pace of that change. But I can tell you that as far as where I'm asked to give One Health type talks or being involved in those conversations has really exploded over the last year or two because I think this information's spreading. And I think things like the websites are helping and getting information to sites where we might not get to physically, but where we can have an impact. Yes?
Back to the very beginning of your talk, which I've enjoyed very much.
Thank you.
You referenced the use of the rodents, and I was curious if you could share your perspective on how well characterized the dog models, using the dog as an example. Because I think when we speak to physicians or folks who are saying, really, do dogs get cancer? And you want to talk to them about the trials in that translational phase, there's always the question comes up is, how much is the dog like the human in all of these various pathways? And so it would seem to me that certainly public funding, other sources of funding to sort of fill out the gaps is very important. Do you have a snapshot on that?
Yeah, I mean, when you say how well characterized, my answer would be not well enough. But I think as we conduct these types of trials, especially with the genetic information, I mean, there's 400 heritable diseases known in dogs. And so I think as we discover those and find their analogous counterpart on the human side, that's where it becomes important. So things like finding the SOD1 mutation in dogs with muscular dystrophy or with degenerative myelopathy looks very much like Lou Gehrig's disease. I think that's a characterization that can help with therapy studies, but certainly there are a lot of other ways you get Lou Gehrig's disease. Same thing with cancer. If we're looking at a specific target, I think we can characterize the tumor very well in that regard, but there may be other aspects of it that are affecting outcome.
So databases, shared databases?
Absolutely, yeah.
And yeah, that seems to be appropriate.
It's huge. I agree. Yes.
Excuse me, one quick thing. I want
Yes.
to remind all people asking questions, identify yourself and your institution, please.
So Kat Lutz, Jackson Laboratory. I had a question for you following up on the previous question about using rodent models. So I think we found out about 10 years ago that mice aren't humans and humans aren't mice, and there's definitely limitations. And that came out resoundingly clear in oncology. Mice get cancer, just like humans get cancer, but it's not the same kind of cancer. And so studying genetic models of cancer in mice hasn't proven to be very useful. However, the xenograph models are giving us a lot of information. So taking human tumors and putting them into mice as avatars, really getting into the deep sequencing and the predictive nature of that tumor has been incredibly powerful. What's going on in the canine field along those regards? Is there any effort to do xenograph and avatar models in canines?
I'm not sure I'm qualified to answer that question. Do we have any lab animal folks that can?
It seems that would be really an interesting.
It seems like it would, but the fact that I can't answer that question would probably indicate that there hasn't been enough done.
I don't think there's a new dog or a skid dog
Right.
that you could transplant.
But you could certainly take the tumors from the dogs and put them in mice and be just as predictive.
Absolutely. And The other thing is there are groups that are funded through the NIH. So we've got a rat resource center, a mouse resource center, and a swine resource center, and those are vital to the research. And I have said it a few times, but I hope I'm not coming off as dismissing those models as being important. But I do think at some point we need to look at the naturally occurring model and say, does that translate?
Can I just make one comment?
Sure.
Michael Oates from the University of Pittsburgh. One of the major areas, as you almost certainly know, in modern oncology is the emergence of the importance of immunotherapy. Mm-hmm. And one of the problems with some of the transplantable models, xenos, is that you edit out the immune response, and it makes it a little bit difficult to understand.
Yep.
If you want to understand what the tumor biology is about, then they're perfect models for studying that in the absence of immune response.
Well, and the other issue in that field is, are there reagents that are specific for the dog? And I think that's another thing that we need to pay attention to.
Can I ask one other question? How
I don't know.
genetically diverse are dogs? Humans are 99.98% genetically identical. What about dogs?
Well, there's been a lot of work done on that, and that's still being determined. There's some recent publications that show, that you can track that through the evolution of the dog. So, the other thing we've got at play is that we've got breeds that are purebred, and then we've got a lot of outbred populations. So I think that becomes difficult to nail down. I'm allowed to take one more, and I don't know how to pick. You pick.
Back here. You. Yeah, sorry.
Hi, my name is Sabina Havate. I'm actually a postbac here at the National Cancer Institute. And I specifically have a question regarding communication specifically. I have a lot of friends who are in medical school, and I often have to explain to them what is One Health and this idea. And I was just wondering, what kind of educational opportunities are there for medical students in the United States and in the world to really gain insight into this concept of One Health?
Yeah, I don't think there's enough, and I think it's incumbent on us to inject that into the curriculum. So things like the fellowships that I'm talking about. I think it's going to be training the newest generation to change that culture. And the other thing we can do is publish in literature that the med students are going to read and that the MDs are going to read. So, I think we tend to focus on the journals that we always publish in. But again, that's probably preaching to the choir. We probably need to get out into some other human journals. And it's always an aha moment. I've never had anybody realize what One Health is and go, well, that's really stupid. It's always like, wow, that's really cool. So, I think it's an idea that just is kind of on a pyramid scheme. You tell two people and they tell two people, and that's what it's going to take. All right, we got a great audience for questions. Thank you guys very much.
So thank you very much, Dr. Henry. As you can see, that stimulated a lot of thinking already, and I would just say that this idea of communication and how to communicate One Health to the NIH is something that we need to be thinking about throughout this conference.